Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the January 2026 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. We'll start with our asthma section. It's currently unclear if all children with mild asthma carry an equal risk for severe asthma exacerbations. In this issue, Sheikh and colleagues evaluate administrative claims data from children with intermittent asthma enrolled in Ohio Medicaid managed care plans for 3 consecutive years to determine if there is a subgroup of children with mild asthma who have a very low risk of severe asthma exacerbations. From the cohort of children considered to have intermittent asthma, a low-risk group of over 3,900 patients was identified based on the first 2 years of enrollment. Then the risk of a severe exacerbation was compared to the rest of the cohort, over 9,200 patients, in the 3rd year. The relative risk of severe exacerbations in the low-risk group was 0.18 compared to the high-risk patients. The number needed to treat to prevent one hospitalization was 5,535, and the cost to prevent one hospitalization was $780,000. These findings suggest that among children with mild asthma, there's a subgroup of low-risk patients in whom current guideline recommendations for first-step treatment may not be needed. Completing this section is a chest review that describes digital respiratory technologies across the lifespan. Our chest infections content area is next. The population-level impact of risk factors for unfavorable TB treatment outcomes depends on their relative prevalence in the population. In this issue, Sinha and colleagues report findings from a prospective cohort of 2,930 adults with drug-sensitive pulmonary TB from 5 sites in India. The study was designed to determine the proportion of unfavorable TB treatment outcomes that can be attributed to key risk factors in India. Overall, 129 people failed treatment, 80 had recurrence, and 101 died. After adjustment for the presence of multiple risk factors, 29% of all unfavorable outcomes were attributed to undernutrition, 15.4% to alcohol misuse, and 17.9% to ever smoking. These findings help to identify intervention targets to improve TB treatment outcomes in India. Our COPD section is next. Mucus plugs occluding the airway in people with chronic bronchitis are associated with increased all-cause mortality. In this issue, Krimsky and colleagues report findings from a study of 55 patients with symptomatic chronic bronchitis designed to determine if bilateral bronchial rheoplasty by basket catheter expansion and delivery of pulsed electric fields to the airway mucosa reduces mucus plugging on CT imaging. 36 or 65% of those enrolled had at least one lung segment with a mucus plug before the intervention. In those with mucus plugging at baseline, the mean segmental mucus plug score was reduced by approximately 1 segment, with 52.8% of patients improving by at least 1 segment. Disconnected airway volume increased at follow-up by 16%. These findings show that bronchial rheoplasty in people with chronic bronchitis and mucus plugging on CT imaging leads to mucus plug reduction at 6 months after bronchorrheoplasty, showing promise for further investigation. Completing the section is a prospective cohort study that explores the association between betel quid consumption and respiratory disease mortality in Bangladesh. Next is our critical care content area. Antibiotic prophylaxis following out-of-hospital cardiac arrest reduces early-onset pneumonia, but has an uncertain impact on mortality and non-infectious outcomes. In this issue, Gagnon and colleagues report findings from a pilot randomized controlled trial with 52 participants designed to assess whether prophylactic ceftriaxone reduces the incidence of early-onset pneumonia without increasing the acquisition of antibiotic resistance genes after out-of-hospital cardiac arrest. The relative risk for early-onset pneumonia was 0.57 in those receiving ceftriaxone prophylaxis. There was a reduction in the use of open-label antibiotics in those receiving ceftriaxone prophylaxis, with a relative risk of 0.64, most of which were broad-spectrum antibiotics. Those randomized to receive ceftriaxone acquired fewer antibiotic resistance genes to frequently used antibiotics in the ICU, with an incidence risk ratio of 0.30. These findings suggest that ceftriaxone prophylaxis in those with out-of-hospital cardiac arrest is associated with less frequent administration of open-label antibiotics and reduced acquisition of antibiotic resistance genes. Two other original research articles appear in this section. The first explores the association between hospital safety net status and delivery of rehabilitation to older adults with acute respiratory failure, and the second reports on contemporary trends in pediatric extubation failure and non-invasive respiratory support use. Completing the section is a special features article on quantifying practice variability to inform the design and assessment of implementation programs in critical care. On to our diffuse lung disease section. Previous mechanistic and clinical studies have suggested that ACE inhibitor therapy may slow disease progression and reduce mortality in idiopathic pulmonary fibrosis. In this issue, Oselton and colleagues report findings from a retrospective analysis of electronic health records from the Clinical Practice Research Data Link GP online database, designed to determine if ACE inhibitor use is associated with reduced all-cause mortality in a real-world population of patients with idiopathic pulmonary fibrosis, or COPD. 3,579 patients with idiopathic pulmonary fibrosis and COPD were included, matched by age, sex, and smoking history. 37% in the IPF cohort and 30% in the COPD cohort were ACE inhibitor users. ACE inhibitor use was associated with improved survival, independent of comorbidities in patients with idiopathic pulmonary fibrosis, with a hazard ratio of 0.82, but not in those with COPD, with a hazard ratio of 1.09. These findings identify an independent association of ACE inhibitor therapy with reduced all-cause mortality in IPF, warranting the conduct of prospective trials. Also in this section is a look at the geographical distribution of phase 2 and 3 pharmaceutical randomized controlled trials in adults with interstitial lung disease, and an inventory of clinical sarcoidosis status in the United States. Next is our education and clinical practice content area. Air pollution and extreme temperature exposure during pregnancy are associated with lung function in school children. In this issue, Hugh and colleagues report findings from 429 mother-child dyads In the Programming, Research in Obesity, Growth, Environment, and Social Stressors study, in order to determine the critical time windows during pregnancy when exposure to air pollution and temperature affects lung function in school children. Prenatal particulate matter and nitrogen dioxide exposures were associated with reductions in several measures of lung function at ages 8 to 14, when modeled as Z-scores that were adjusted for age, height, and sex. Both warmer temperatures at weeks 1 to 8 and colder temperatures at weeks 9 to 18 showed positive associations with the FVC Z-score. Stronger associations were noted in female participants, and no interactive effects of air pollution and temperature were noted. These findings highlight detrimental effects of early life air pollution exposure on long-term respiratory health, informing the development of targeted interventions to protect child health. Also in this section is a scoping review on the failure to report sex-specific risk factors in heart failure with preserved ejection fraction research. Completing this section is a How I Do It review on transitioning from race-specific to race-neutral reference equations for pulmonary function test interpretation, and a point-counterpoint debate on whether pulmonary and critical care medicine fellowships should require advanced cardiac point-of-care ultrasound competency. Our pulmonary vascular content area comes next. Manual interpretation of echocardiography can be time-consuming and prone to error. In this issue, Celestin and colleagues aim to determine if a fully automated deep learning workflow in echocardiography is reliable when assessing for pulmonary hypertension. The first part of the study evaluated the bias and precision of deep learning reads using core lab readers as the reference in 213 healthy individuals and 221 patients with pulmonary arterial hypertension. The second part assessed the ability of deep learning to discriminate milder pulmonary hypertension in 196 patients referred for right heart catheterization. No significant bias was noted for peak tricuspid regurgitant velocity, right atrial area, and tricuspid annular plane systolic excursion, while a bias of 11.5% was noted for right ventricular fractional area change. In the case control evaluation, peak tricuspid regurgitant velocity had areas under the curve of 0.99 and 0.98 for core lab and deep learning reads respectively. The AUC for pulmonary hypertension detection in the referral cohort was 0.79 for clinical lab reads and 0.75 for deep learning reads. These findings identify the promise of automated deep learning workflow for echocardiography in the assessment of pulmonary hypertension. Completing this section is a How I Do It review on the evaluation and management of pulmonary hypertension associated with interstitial lung disease. Next is our sleep medicine content area. There are limitations to the use of hypoglossal nerve stimulation to treat obstructive sleep apnea, including cost, invasiveness, and variable efficacy. In this issue, Osman and colleagues evaluate whether hypoglossal nerve stimulation applied via percutaneous implantation of a linear multi-pair electrode array can restore airflow to airway narrowing, obstruction, or both in 14 people with moderate to severe obstructive sleep apnea undergoing drug-induced sleep endoscopy. The mean peak inspiratory flow was 0.43 liters per second when receiving therapeutic CPAP. This fell to 0.1 liters per second during CPAP reduction and increased to 0.41 liters per second, similar to that achieved during therapeutic CPAP during hypoglossal nerve stimulation. The mean active P-crit was negative 7.2 centimeters water with hypoglossal nerve stimulation in 0.1 centimeters water without hypoglossal nerve stimulation. These results show that acute hypoglossal nerve stimulation via a minimally invasive percutaneous ultrasound-guided approach leads to airflow increases equivalent to therapeutic CPAP and improves airway collapsibility in people with obstructive sleep apnea. 2 additional original research studies appear in this section. The first evaluates the consistency of hypercapnic respiratory failure case definitions in electronic health record data. The second is a method comparison study that explores how using different oximeters may affect clinical decisions in patients using CPAP or non-invasive ventilation. Next is our thoracic oncology content area. Differences in underlying characteristics between the population undergoing lung cancer screening and lung cancer screening trial participants may alter the benefits of lung cancer screening. In this issue, Rivera and colleagues used data from the North Carolina Lung Screening Registry, the 2022 CDC Behavioral Risk Factor Surveillance System Lung Cancer Screening Module, in the National Lung Screening Trial to determine if the risk of lung cancer developing and death resulting differ between trial participants and the general population. Behavioral Risk Factor Surveillance System and North Carolina Lung Screening Registry populations were older, had higher rates of COPD and prior history of cancer, a higher risk of lung cancer developing and death resulting, compared with National Lung Screening Trial participants. Median 5-year lung cancer risk was 21.2 per 1,000 National Lung Screening Trial participants, 34.5 per 1,000 2021 Behavioral Risk Factor Surveillance System participants, and 32.3 per 1,000 2021 North Carolina Lung Screening Registry participants. Median 5-year probability of dying of lung cancer, if not screened, showed similar patterns. These findings show that populations undergoing lung cancer screening may have similar smoking exposure to NLST participants, but have higher prevalence of lung cancer risk factors and risk of developing and dying from lung cancer if not screened. Also in this section is a study that explored medical thoracoscopy with versus without prior artificial pneumothorax for patients with minimal or absent pleural effusion, a report on the implementation of a precision medicine thoracic service using in-house reflex testing in a large academic community practice, and a randomized controlled trial of behavioral support by ex-smoking peers using instant messaging to help with smoking cessation. I encourage you to read our commentary series, where you will find a description of the bronchiectasis and non-tuberculous mycobacterial care center network, and from our statistical series, a pace on a data-driven latent class analysis approach to identify subgroups in clinical research, as well as our humanities series, where you'll find an exhalations piece titled An Evolution. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the January issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.